Welcome, everybody. Today, I have Jamie Bergner, who is a certified hand therapist, and she's an educator, and she's going to be lecturing on the wrist at the summit. But I'd like to just first extend my warm welcome to you, Jamie. Thank you so much for joining us.
Thank you for having me.
No, it's such an honor. Jamie, tell us a little bit about yourself. We're really interested in kind of why you became a hand therapist, what your experience is to date leading up to where you are in your career at the moment, and also how you got into hand therapy education.
Sure. Well, I was trained in the 90s as an occupational therapist. And so that was kind of the era when evidence-based practice was just kind of emerging as a concept of how do we integrate this evidence into our practice? And so I think that was kind of an early foundation for me at looking at the research and really came out not sure how to do that process. So I dove deeply into how do I become an evidence-based practitioner? And what I found through that process of seeking is that I was learning how to become an evidence-based practitioner. As an occupational therapist, I started out very broad. I worked in pediatrics, acute care, home health, just outpatient, hand therapy, neuro, lots of different things. I just loved being an occupational therapist and helping people get back and to their everyday occupations, as well as like training their families on how to care for them. So I started out broad, and then as I narrowed in, I always had a hand therapy caseload. And it just seemed like I kept digging deeper into the complexity. I loved the intricacy of hand therapy. As my career went on, I started to get a little bit more traumatic injuries. Again, went back and how do I treat these effectively? And so I would continually try to search for those answers. And that led me to getting my certified hand therapy credential in 2010. And then from there, as I practiced, there always seemed like there was more to learn, which still is today. There's always so much more we can learn and grow from. But at that time, I took my first manual therapy course, and I really was actually blown away at the complexity of those courses on looking at the joint, but the ligament system, the muscles, how that all works together for our patients. And so I continued on and got my manual therapy certification through the International Academy of Orthopedic Medicine, US. And my mentors were so great through that, Ann Predelerke and Mirka Normand, that I just want to stay connected with them in some way. So during my certification exam, my husband was my test patient, and I just said, I blurted out, I want to teach with you, because in my mind, I'm picturing I'm just going to be your groupie and follow you around and learn from you. So my husband looked at me like, have we talked about this? You do know this means that you have to stand in front of people and teach, right? And so I think I truly wanted to join to be a learner more than a teacher. But what I found with that experience is how great it was to collaborate with other clinicians and travel across the United States and teach and really connect with individuals all over and learn their perspectives of things. And in the process of that, I relocated to Nashville, Tennessee from Wisconsin originally. And I worked for Vanderbilt University Medical Center in Nashville, Tennessee, and really learned to specialize in traumatic injuries and trauma, and looking at, as complex as that can be, really the human factor of it, of relating to all of the psychosocial issues that go from limb loss to mangling injuries and trauma. So it kind of feels like I came back full circle to my occupational therapy side with that. But in the process of that, I started collaborating more with research, and I felt like I couldn't keep up fast enough. So the surgeons and the physicians that I was on teams with had wonderful fellows and residents to do their searches for, but as therapists, we were trying hard to keep up just to manage a full clinical schedule and then also be involved in these research teams. So I went back for my clinical doctorate in occupational therapy through Rocky Mountain University of Health Professions in Provo, Utah, and got my clinical doctorate through them. But then what I realized is that I really want to be in charge of my own projects. And so started first by just really exploring the wrist. I love the complexity of the carpal kinematics. And it's, we were talking about this earlier, Robyn, it's almost like you're pulled up in your seat and you're watching this great movie, you're eating your popcorn, and then a new study comes out that says, oh, it's all about the dart throwers. And then we learn, oh, it's actually the ligament doesn't support the whole wrist. It's a neuromuscular control system. And it's an exciting time to be looking at the wrist, I feel. So I really am connected with that. I started with a scoping review to really look at the biomechanical literature, published that in the Journal of Hand Therapy in 2020, I believe. It's such a long process for review and in publication, you lose sight of the dates. But and then we embarked on just an in-clinic, how do we measure dart throwers motion? And how, if it's such an important role with that proximal carpal roll, like how are we as clinicians going to assess that? And is there a way we can do it with accepting some variability in that measurement? Because we know it's oblique and hard to measure. So then looked at a 30 subject, basically an IRB approved study of our friends in the clinic to see normal healthies. Is this even possible? We found that it was. And so then we are embarking further on prospective studies with looking at our patients and what does their range of motion look like for that oblique motion. So I think those early years kind of came back full circle through the trauma, and the research aspect of it is exciting to be able to even contribute in small ways to that. So, but that's how I got into teaching and research and clinical practice. And I'm still a full-time clinician at Vanderbilt. So I do that as well as I teach through Cox College now, an online course for graduate students, for Master's of OT students.
Wow, I am in awe of you because I know what that takes. And it's so much time and dedication. And you're a mom. Yeah.
Yes. I'm a mom of two kids. My daughter is 15 and my son is 10. And then we also adopted a puppy we called it the puppy pandemic because our whole neighborhood got puppies in the pandemic, and because everyone was staying home for a while. So we invested in the Labradoodle, and that's our hairy third child. He's on a walk right now, so he doesn't disrupt.
That's wonderful. I think it is incredible how you've always dived so deep. You went and got your doctorate. That is huge. And I think one needs that if you are going to be an educator, because you need to be a critical and analytical thinker, and you need to be able to expertly scan the literature, do your literature searches and analysis, and also, work on your publications. Have you had a mentor help you with publications, or is it writing something that's come naturally to you?
Yes, I have a PT PhD that's, his name is Rogelio Coronado, and he has been really helpful in navigating the research waters, because you really definitely need a mentor in that area that really has that researcher role, that's their job, to be a researcher. Yes. As a clinician, I think that makes a really nice match, because we have a lot of burning questions that we want to know the answers to. And they are the experts in research design and making sure we do research ethically. So I've been very fortunate to have someone at Vanderbilt that's been my mentor for research too.
You reminded me of my days at Guy's and St. Thomas Hospital, because it is an academic hospital. And when I first got the role in orthopedic hand therapy, I met this amazing surgeon. And the first question was, are you interested in research and publication? And I just wanted to impress him. So I said, yes, absolutely. And then he would appear at my door and say, okay, let's begin. And it was so wonderful, because he actually wanted to mentor me to do a PhD through the Swedish university. But at that time, I just couldn't take it on. I was happy to just learn from him and learn to publish. And I remember him saying something to me that I'll never forget, because we had done a pilot study and I had to sit and write it up. And he said, imagine that you're starting with a block of ice and you're an ice sculpturer, and you're just going to take your chisel and your hammer and you're going to hammer away. And he said, initially you won't see the beauty, but as you keep going, so the beauty emerges from the structure and you end up with your finished product. And really, that is exactly the process when you are publishing.
Yes, it is definitely something that I think as clinicians, when we're asked if we want to do research, we all say yes. And then the more you get into it, you're like, oh, wow, this is a lot. And so I have the ultimate respect for those that have given their lives and their careers to just doing research, because it's such a huge endeavor. But at the same time, we need clinicians involved in that process too. And what I found a little bit with my surgeon teams is they're interested in surgery. And so they really don't really always understand what we do in the therapy clinic. And so I think it's important that we have therapists step up and be principal investigators and really kind of drive those projects, but in a way that's supported and rigorous too. So we need that collaboration with our surgeons, but we also need to make sure we're answering our questions too.
Absolutely. And I think also making it clinically relevant. And so we do want to walk down a path that is going to change practice. And I'm seeing and hearing that more and more at the conferences. Do you agree?
Yes, definitely. And the importance of good mentors too, and mentoring others as well in the process, so that we're helping each other.
So you're going to be teaching us about the scapholunate ligament and ligament instability. Can you tell us a little bit more about your talk and what you're going to be teaching?
Yeah. So the scapholunate interosseous ligament, we know, is one of the important key players of the wrist carpal kinematics and the ability to bear load and keep everything linked together in that proximal row. But one of the things that we don't always emphasize is the importance of the neuromuscular control system. And so the ligament can bear the load of both the radial column and the central column, but it functions more to alert when there's too much pressure, because the SL ligament can only take, that dorsal limb of it can take 68 pounds of pressure before rupture and cadaver. So why would we think that would be the only thing that we could protect and stabilize and get healing? So that neuromuscular control piece of it's really important. But also giving that proximal row a chance to heal by looking at other ways we can improve our function. So the mid-carpal joint is a key player that we want to get moving well. One of the things clinically I see is that when we have an injured segment, everything around it sometimes can stiffen up as well, and try to provide that internal bracing or support that we often see, very much like our swelling does in a fusion, to try and stabilize an injury. And so then we lose that ability to move the ones that actually could offload that ligament, and it accentuates that load bearing through the SL. So this talk is going to dive deep into anatomy and look at those relationship pieces, but it's also going to bring it around to the evaluation. What do we do in the clinic for that? And then when we do find that we have a pre-dynamic DZ or dorsal intercalated segmental instability, what can we do as therapists to offload the ligament and help progress its rehabilitation? So hopefully you'll walk away with some answers to those questions.
And you're also going to be teaching us a little bit about how to implement a proprioceptive rehabilitation program.
Yeah. So once we get things moving around the joint so that we can offload those through manual therapy techniques, then we want to start getting that fast, efficient, reflexive type activity from the ligament. And so we'll talk about some clinical activities that can accomplish that.
I must say, I absolutely love treating the wrist, and it's wonderful to take a patient through a proprioceptive rehab program, because it's not a vigorous program, it's not a painful program. They often wonder how these exercises are going to do any good because they're so gentle. But I mean, it is just that. It's about strengthening the intrinsic ligaments and creating that neuromuscular feedback loop.
It's interesting when I talk with patients about it that are struggling with that aspect of it. I use the analogy of the hula hoop. So when you're using a hula hoop, you can't mechanically move, or the hula hoop just falls to your ankles. So if you're trying to use a hula hoop, if you've used one, as hopefully you've tried that, because that's a lot of fun.
Yeah.
You can't think about it. You have to feel the movement and respond quickly to it. And so when we look at some things like power balls or to move without thinking about it is really the system we want to tap into. It's that non-conscious neuromuscular control that really, when we kick into that, that's when we know we've got our ligament in pretty good shape.
Well, I'm going to be stealing that analogy from you for sure. That is beautiful. And it's amazing how we do come up with those little clinical pearls to help. And I think that's what I am really appreciating about our career and about how we all relate as colleagues, because it's those little pearls and sharing of those pearls that really ends up helping the patient. And that we're all really we're there for the patient first and foremost.
Yeah, I 100% agree.
I also would just like to highlight how important our rehab is, because I recall being at a conference many years ago. It was one of the IFSHTs, and it could have even been in Delhi, where Mark Garcia Elias was speaking about how they used to, do four-corner fusions and proximal row carpectomies and, implement all these procedures, which are so invasive. And now there's just such a strong move towards abandoning those approaches for a time being and referring the patient to therapy and having us implement our treatment, particularly our proprioceptive protocols. And I feel that's so important that we as therapists do that therapy justice by spending the time to learn that anatomy, learning from experts like yourself, and making sure that we are doing the right thing, because we can very often do no harm, but we can also do no good.
Correct. And I think one of the two things that I used to see with the wrist a little bit more when I'd ask surgeons, like, what do you do when you find pre-dynamic instability or a dynamic instability of the SL ligament? And often the response was, well, we wait until it gets bad enough and then we fuse it. And so it's wonderful to have another option for these patients rather than just being in pain. But I think you touched on something really key, that is we can hurt our patients too if we don't understand it. And, early on, I would see sometimes, the putty put in the hand in a supinated position and grasping. And what we know about that now mechanically is that's putting our ECU in a very mechanical advantage to separate the SL ligament. But it's also impacting that capitate into the SL ligament. And so we're doing harm on both aspects of it, mechanically, kinematically, as well as kinetically. And so understanding that better, we can do better now.
One of my other heroes is Elizabeth Haggart, and I just absolutely adore her and the work that she's done and her papers that she's written. And so we developed a proprioceptive program, and I use a Frisbee, and put a ball and get that patient to work the Frisbee. But in one of her updates and one of the lectures I attended, she's even changed that to where we actually put a handle under the Frisbee and actually work it with the wrist in the neutral position. So for a time, I was doing it incorrectly by getting the patient, to supinate. And now we're keeping that wrist in neutral. So it just again highlights how important it is to keep up to date, keep liaising with our colleagues, attending all the lectures, and just really communicating.
Mm-hmm. Well, and it's an evolving science. Like the way we're treating the wrist now is totally different than 10 years ago in the clinic. And I expect that it's going to continue to evolve, and in 10 years, we might be doing something different as well. So it's exciting to see the changes with it.
What I'm also finding fascinating is if we just scrape the skin, we get joint motion. And so sitting and doing passive and active mobilization exercises of the wrist is often the last thing I do now. I first go proximally and I'm doing a lot of skin scraping. Do you do IASTM in your practice? Have you also found that if you just do that, you can get joint motion?
In some cases I have, but not in all. And I think the more you're right, the more we understand the details of the system that we're working, the nervous system, the electrical systems, how that interplays, as well as with the fascia and the skin and the movements of the joints. But also zooming out even further to seeing the whole person and how they're interacting with their environment. And so I think, as therapists, as we learn more detail about our systems, it's like we got to zoom out as well and see how that participation is affected. So I think it's like almost like a camera. We're zooming in, zooming out constantly to see, okay, what's causing this impairment, and then relating that back to what the daily life activities are. So, and I love the work with looking at pain and, how long has that pain been going on in the wrist? Is it something that we need to look a little bit more at our brain mapping and our proprioceptive systems? And is there other systems at play from having chronic pain and the psychological impact of that? So sometimes some of those things with meditation and relaxation are needed too. So it's wonderful at this point in time to have so many different tools in our toolbox to be able to grab and use to help that patient re-engage again. Balance of going in and out. Because in early stages of my career, I saw general treatments that maybe weren't as effective either. So knowing the detailed zooming in piece of it, but then keep coming back out to see how that interplays with the entire body and the whole system.
Well,
100% agree.
We've all got so much to learn, and that's what I love about our profession and our career. There's just no room for ever feeling that we know it all. And I'm like you, I want to be a learner forever, or a student forever, so that we can keep learning and keep growing that knowledge, so we can help, not only help each other, but help our patients. Mm-hmm. But I just want to thank you so much for your contribution to the summit. And also just being able to share so many practical tips and techniques, and for extending the opportunity. Thank you very, very much.
Well, thank you so much for the invite. I look forward to attending the conference as well.
Okay, we'll see you there. Thank you.